So, assessment of acid-base homeostasis, and now starting from the bicarbonate buffer system. So, for the bicarbonate carbonic acid buffer system, the dissolved CO2 is in equilibrium with the CO2 gas, which can be expelled by the lungs. But because the CO2 can be removed, the bicarbonate buffer system is in fact referred to as an open system, because CO2 can be removed. It is not a closed system because the end point is that CO2 should be removed. So the lungs participate rapidly in the regulation of blood pH through hypoventilation and hyperventilation, and you know that kidney is also a non-respiratory component, and it is called metabolic component, and kidneys can control bicarbonate concentrations as well. So in the plasma, for example, in the plasma, when the patient is at 37 degrees temperature, body temperature, so always the pKa of this system is 6.1, right? And the concentration of carbonic acid is proportional to the partial pressure of exerted by dissolved CO2, right? So always in normal temperature, carbonic acid concentration is proportional to the partial pressure exerted by dissolved CO2. So that's why CO2 can be also compared with carbonic acid. It can be also a component of acid. So the factor to convert millimeter of mercury to the millimole per liter is 0.0307 millimole per liter per millimeter of mercury. So when you want to convert, for example, when you have a certain unit in a millimole, for example, you may have the amount of CO2 in millimeter of mercury, then you can convert it to millimole per liter by multiplying with 0.0307. So, and also both pH and partial pressure of CO2 are measured in the blood gas analysis, and pK is constant. Then you can be able to calculate bicarbonates. So pKa is constant, it's just 6.1, and you can also measure the pH and partial pressure of CO2, and then you can calculate the pH. For example, pH can be calculated, or anything here can be calculated using Henderson-Hasbach equation. So let's look at the Henderson-Hasbach equation. That's how it looks like. pH is equal to the pKa plus logarithm of concentration of bicarbonate over 0.037 times partial pressure of carbon dioxide. So because we have said that partial pressure of carbon dioxide is now proportional to the concentration of acid, so that's why we don't put acid here as a denominator. So we just put partial pressure of CO2 because it is proportional to the concentration of acid. So, and when you take 0.037 times this, it will always mean that you are trying to convert CO2 in millimole of mercury to millimeter of mercury to millimole per liter. So using the formula, then you can be able to calculate the pH. So when you calculate pH, you can just replace it with the pKa. pKa is just 6.1 plus logarithm of the concentration over this concentration of partial pressure of CO2. So then when you do that, you find that in normal person, you find that pH is 7.35 to 7.45. Partial pressure of carbon dioxide, it must be between 35 to 45. This is the millimeter of mercury. Then you can convert it to the millimole per liter if we need it. And bicarbonate ion should be between 22 to 29. This is the normal range for bicarbonate ion. So total carbon dioxide content must also be 23 to 27, which is a normal range of 24. And also partial pressure of oxygen should also be between 85 to 105. Then oxygen saturation can also be at least greater than 95%, and hemoglobin should also be reflecting 95% and above. So these are the normal ranges that we are going to use and also try to compare the result and the condition that might have happened So when kidneys and lungs are functioning properly, so the ratio between bicarbonate and carbon dioxide must be, bicarbonate and carbonic acid must be 20:1. So 20:1 means it is just a ratio. Sometimes also there's one thing that some people used to fail. Sometimes they can reverse it. They would say, what is the ratio between bicarbonate? What's the ratio of carbonic acid to bicarbonate? That is like to revert it back. So if they do that, then you have to remember that 20 represent bicarbonate and carbon dioxide is represented by number 1 like this. So then it will help you not to be puzzled or not to panic, because maybe here they have started with the carbonic acid and you are familiar with that ratio of bicarbonate and carbonic acid is 20:1, but ratio of carbonic acid and bicarbonate or to bicarbonate is 1:20, is not 21. So, and this is corresponding to the normal pH of blood, which is 7.4, and this can be calculated by substituting normal value of bicarbonate and partial pressure of CO2 from the preceding equation. So then you can substitute our variables here using this formula. When you substitute the carbon dioxide, which is 24 over the partial pressure of CO2, then we substitute, then we can get then the ratio of 20:1. So ratio of 20:1 is very important. For example, here we have 24 here as a numerator. So this is the concentration of carbon dioxide, bicarbonate ion in millimole per liter. Then we can also say that 40 millimeter of mercury is a partial pressure of CO2, but times 0.037, and then we get 24 over 1.2, which gives us 20:1. So this is where our ratio is coming from. So the ratio is always coming from Henderson-Hasbach equation. So the normal pH of blood is 7.4, and this can be derived from by adding a logarithm of 20, which is 1.3 to the pKa of bicarbonate system, which is 6.1. So this is how you get the pH. pH is not coming from nowhere. It's not coming from nothing. pH is also coming from Henderson-Hasbach equation. So because pH is equal to pKa plus logarithm of this formula here we have here. So logarithm of this formula, it is 1.3, and we can add it to the pKa, which is a constant 6.1. Then you get 7.4, which is normal range, normal pH of blood. Now, let's look at these disorders. If you have some time, let's look at these disorders, alkalosis and acidosis. So, acid-base disorders can be classified as acidosis and alkalosis. And in fact, when a patient is experiencing acidosis, then it means acidemia, because that acid in the blood, it's acidemia. On the other side, it is called alkalemia. And acidemia will just result if hydrogen concentration increase through increased partial pressure of CO2 concentration or decrease in bicarbonate concentration. So this is what happens for a patient to experience acidemia. It is only when there is increase in CO2 or decrease in bicarbonate, there will be acidemia. So, but alkalemia is just a result of decrease of hydrogen ion concentration or decrease of CO2 or increase in bicarbonate ion. So all will be associated with alkalemia. So the disorder caused by ventilation dysfunction is called respiratory acidosis or alkalosis, and the disorder which result from bicarbonate level problem, it will be non-respiratory or it will be metabolic disorder. So we have primary metabolic disorders. It can be acidosis or alkalosis. We also have primary respiratory disorder. It can be acidosis or alkalosis depending on the case. So the response to maintain acid-base homeostasis is called compensation. What is called compensation is ability to monitor and to maintain acid-base homeostasis compensation. So compensation is accomplished by altering a factor that is not associated with the primary process. I hope you understand what is compensation. It is like to compensate for kidneys if the problem is a kidney. Which will compensate is lungs. Lung is going to compensate for what is going on in the kidneys. So then it means respiratory components will compensate for metabolic components, and metabolic component will compensate for respiratory components. So the lungs can immediately compensate for the problem which is caused by kidneys by removing CO2 or retaining some CO2. For example, if someone is having alkalosis, of course, the body can try to retain some carbon dioxide. And when the body is experiencing acidosis, so the patient will try to expel a lot of CO2. So, but this is, even if lungs can be able to compensate, full compensation is not a full compensation, and it is always called incomplete. So it is called partial compensation of the lungs. But the kidneys can compensate by excreting and reabsorbing some ions, for example. So when the kidneys are absorbing or excreting some ions, it is now, this compensation, it is long term and is a sustained compensation. So which means that kidneys then on the other side can compensate fully or completely. So there will be a full compensation status of the kidneys. And how will you know it is a full compensation? You will know that it is a full compensation when pH has returned to the normal range. When pH returns to the normal range, it is then a full compensation. Otherwise, if compensation happened but pH seems to be out of range, it is always a partial compensation. Even if pH is approaching normal, it is not a full compensation. So in fact, in case of primary metabolic acidosis, this is of course in case of metabolic acidosis, so the amount of acid exceeds the capacity of buffer system. Of course, this is correct in metabolic acidosis. It means there is a high amount of acid which exceed the buffer system. So it can also be because of decreased concentration of bicarbonate, less than 24 millimole per liter. And also sometimes, of course, it results in decrease in pH. So that is primary metabolic acidosis. So what happened in primary metabolic acidosis? There will be, of course, alteration of our Henderson-Hasbach equation. And you find that the patient is getting less than 20 and 1 hour ratio between bicarbonate and carbonic acid. So the body will just compensate for metabolic acidosis through hyperventilation, because as we said, body can compensate, lungs can compensate for metabolic components by hyperventilation, which is increase in rate of breathing and depth of breathing, because this is like blowing off carbon dioxide in order to normalize the carbon dioxide in the body. So, but this compensation is not really adequate and is not enough until the secondary compensation happens done by kidneys, because even if lungs can compensate, but they can't compensate completely. So they require kidneys to begin to correct this ratio by excreting some hydrogen ion and reabsorbing bicarbonate ion. So as you can see now, even if compensation could take place, but finally kidney must act to fully compensate for pH to return to normal. So there are some causes of metabolic acidosis. They are all the causes. So then primary respiratory acidosis. So we could also see primary respiratory acidosis, which is a respiratory acidosis associated from or resulting from a decrease in alveolar ventilation. This is some conditions that can cause hypoventilation. For example, someone with the emphysema or someone with the pneumonia, sometimes someone with the COVID. So those patients, sometimes they may experience hypoventilation because of damaged kidney, damaged lungs. So if lungs are damaged and they cannot really expel enough CO2, that condition is called primary respiratory acidosis, which is also going to fluctuate our normal ratio between bicarbonate and carbonic acid. So what will happen is that the compensation now will happen through metabolic process, because now what is going on is respiratory disease. So but as the metabolic process, unlike the respiratory, this require some time, hours or days, to affect pH. So this take long time. So but even if it takes some time, kidneys can fully compensate by excreting hydrogen ion and reabsorbing bicarbonate ion, so which result in restoration of pH back to normal. So when something is happening in the lungs, kidneys will just reabsorb some bicarbonate ion. For example, if the condition is respiratory acidosis, there will be compensation by reabsorbing some bicarbonate ion. That is what you will see in your results, that even if CO2 is high, but also bicarbonate ion is high, that will tell you compensation is going on. So there are some causes of respiratory acidosis. Of course, the problem of output of the lungs, of the heart, and so on. So, but in primary metabolic alkalosis, this is in case of alkalosis, but not really acidosis. So what happens in alkalosis? In fact, this results from gain in bicarbonate ion, which causes pH to increase. For example, if someone is taking drugs that contain bicarbonates, so patients will experience alkalosis because of gaining bicarbonate, which increases pH of blood. So hydrogen ion with the sensor in the brain will be sensed in the brain, and then the brain will command respiratory center to depress respiration, which result in hypoventilation and retention of CO2. So you can see, because this is a primary metabolic alkalosis, what happens quickly is that lungs can now try to retain some CO2 by depressing respiration, by reducing ventilation, which is hypoventilation process, in order to retain some amount of CO2 and increase CO2 by lowering pH, trying to lower the pH. But however, this process is not reliable and is very hectic, because even though it happens, it is also increasing problems, because when lungs are trying to conserve CO2 and CO2 is toxic, that's also an unreliable process. So what will happen ultimately? The primary cause of metabolic alkalosis must be corrected. If maybe it is metabolic process, like you are taking drugs like sodium bicarbonate ingestion, excessive loss of acid like vomiting, there must be a certain correction somewhere else. But lungs cannot restore pH at all, because lungs cannot compensate fully. So finally, we have primary respiratory alkalosis. This is about alkalosis, but which result from increased rate of alveolar ventilation, which causes excessive elimination of CO2. So for example, if someone is having, like, for example, hypoxemia or chemical stimulation of respiratory center by drugs, for example, some drugs can stimulate hyperventilation. When this happens, patients experience excessive elimination of CO2 from the lungs, If this happens, is what we call primary respiratory alkalosis, and this also is going to fluctuate our ratio between bicarbonate and carbonic acid. So the kidneys compensate by excretion of bicarbonate in the urine and reclaiming hydrogen ion to the blood, right? So this is what happened for, because this is a primary respiratory alkalosis, it will be corrected by kidneys themselves by, of course, excreting excessive amount of bicarbonate and trying to reclaim some acid in order to restore the pH. But of course, finally, kidneys will restore the pH, and we will see compensation of increased bicarbonate and increased hydrogen ion in order to restore that pH. So this is, let's just meet again maybe tomorrow in order to look at oxygen and gas exchange, and also we will also look at assessment, lab diagnosis, or testing for this pH, bicarbonate, carbon dioxide, hydrogen ion, and even saturation, partial pressure of CO2 and oxygen. All of the things we will look at them tomorrow. So it is very important. So we try to look at some questions in acid-base imbalance, because some questions can look tricky, because some people don't, if they don't really understand exactly what happens during compensation, sometimes questions may challenge you, because you find that what you expect as a finding or a given data is not really reflecting what you think. So that's also a problem. So maybe we'll have to go through questions, and I will show you how you can know, even if you have seen the result but that you didn't expect. It is probably because of compensation or partial compensation or something else. So that's one we'll have to look at, like 5 questions, different questions, in order to understand what happens during this acid-base balance, because acid-base balance is a quick mechanism which actually takes compensation happens just in a few minutes. So that's why whatever you expect as a result, you cannot get them because of that kind of fluctuation during compensation. So thank you so much for your time. Let's meet again in next presentation of chemistry, but of course we're going to meet soon again in hematology. So God bless you, and we'll keep in touch, and see you soon.